talked about the withdrawal reflex, right? So the fact that you actually have to use an interneuron to connect from the sensory to the motor, as well as actually sending a signal, a sensory signal up to your brain, through your spinal cord, indicating what has happened, right? So you have to have an excitatory and an inhibitory signal. Now, that's for one single limb, right? So you reach out, you touch something hot, you contract your flexors, you inhibit your extensors so that you contract away from it. This is another polysynaptic, little bit more complicated, right? So what we're going to see is you have a painful stimulus that occurs, right? When that painful stimulus occurs, the signal goes up, again, through a sensory neuron. It bypasses your dorsal root ganglion, goes into, right, the sensory nucleus, where it will now synapse with an interneuron, right? So the interneuron is the white one, and then for the interneuron, it's going to send, right, of course, a signal up, right, so that you go up towards your brain, right? It's actually going to send a signal out to the motor on the same side, okay? Now, this is important, is you have to understand this term. So, ipsilateral means same side. Contralateral means opposite side, okay? So what we're dealing with is, you're actually sending a signal to the ipsilateral motor nucleus. So you're going to synapse here, ipsilateral, right? Now the truth is, it's actually going to go to both, right, extensors and flexors on this side, right? So you're actually saying that you're sending a signal to both extensors and flexors in that motor neuron. And the reason why is because what you want to do is you want to send a signal down to your flexors so that you're going to initiate flexion on that same side. So they're using the, like a tack or a piece of glass or something hot that's on the ground. You're, stepping down, and when you're stepping down, you actually don't want to continue to step down. You want to move away from it. So you have to contract your flexors. So hip flexor, right, knee flexor. You want to contract those and move away from it. So the flexors are excited. You initiate contraction. Remember, at the same time, you also want to send a signal down to your extensors because you want to inhibit those extensors. Now, the problem with this is, if you're talking about your leg, right, you're taking a step and you go like this. So you're going to put your weight onto this leg. If I then take my flexors and I contract them, and I'm trying to put my weight on this side, and obviously I'm overstepping, so I'm exaggerating, but if I do this, and now I contract my flexors, what's going to happen? That's what's going to happen. It's not going to support my weight, right? So you have to actually contract muscles on the contralateral side as well. So I'm exaggerating it, right, for effect. But what you have to realize is the signal also has to cross over to the contralateral side. So what you're now going to do is you're actually going to stimulate neurons on the contralateral side. So we're going to contract the extensors. So in this case, we're going to contract the extensors on my opposite leg, and then you're going to inhibit the flexors. Because when you're taking this step right here, what you don't want is you don't want this leg to just collapse and you can't support your weight. So if you're going to lift this leg back up away from the painful stimulus, you have to contract your extensors so that this leg extends out, and you do this, and you actually balance your weight on the contralateral leg. So this is a much more complicated reflex, right? Same thing though, this is not conscious. It does not actually have to go up to your brain, right, in order for this to happen, okay? Now, one of the things that you should understand about this, right, is this has the least number of synapses possible, okay? So really, you're going to synapse here when you get from your sensory to your interneuron. And then at that point, right, the interneuron is sending its signals out. And yes, there are multiple targets, right? But at each one of those targets, it's one single synapse, one single synapse, one single synapse, one single synapse. Does that make sense? Right? And then you get to your target, and it's not actually a synapse. right? It's called a neuromuscular junction. But this is the minimum number possible to initiate this complex series of contractions, muscle contractions, or inhibitions, all right? And that's important because you don't want a lot of synapses if you're trying to initiate the reflex as fast as possible, okay? Because the electrical signal travels very, very, very fast, right? For our intents and purposes, it's instantaneous. There's always a slight delay at the synapse, okay? Now, does anyone have any idea why? Why is there a delay at the synapse? You're super close, right? There's actually, essentially, there is no delay for the molecules, the neurotransmitters to cross the synapse. Because they're not touching, the neurons are not touching, but they are so close that the crossing of the synaptic cleft, instantaneous for our purposes. So where's the delay? No, because the electrical part, super fast. That's almost instantaneous too.
Deciding
what?
Deciding which.
No, because there's no decision. No decision. Releasing the neurotransmitters. That's what takes the longest. Is you have to have the calcium come in, and then the vesicles actually have to move, bind to the plasma membrane, and then release the neurotransmitters. That's where the delay is. Every single time there's a synapse and you got to release neurotransmitters from the vesicles, it takes a little bit of time. Which is why it's important that when you have reflexes, minimum number of synapses possible. Okay? So for something super, super simple, right? Like really simple, like a stretch reflex, right? One synapse. That's it. All it takes is one synapse because you don't want any delay, because delays could mean that you actually have an injury. Okay? So that's just reflexes, right? Which are involving sensory neurons, which are either directly or just, one interneuron separation from the motor neurons. And what kind of motor neurons are we talking about here? Lower motor neurons. Because remember, this does not have to go up to your brain and then you process and go, oh, I should lift up my foot. It just does it automatically. Only involving the lower motor neurons, not the upper. You will sense it, you'll know that it happened, but you don't have to process that and then make a decision, okay? Okay, so. Now, talking about the nerves themselves. So now we're still talking organization, and we're going to talk about protective coverings for the nerves themselves. And essentially the protective coverings, they are referred to as meninges. So this is plural. That's really terrible. You can't read that, can you? Meninges. So that's a plural word, meninges, okay? And then the singular, right? You don't have to know it, right? Is meninx, right? The three that we are talking about, if you're talking about, right, this white material, right here, this white material, that's the nervous material, okay? And you'll notice that there's a layer that's right on top of the nerve, or I should say the nervous material, right here, the neural material right there. So this layer that we're talking about right on top of it, this is referred to as pia mater. Every single meninx is called mater, right? It just means mother because it's something that nurtures and protects, right? So pia mater is the soft mother. Pia just means soft. And it's directly adhering to the neural tissue, okay? Now, when you look, right, this is just the central nervous system that we're dealing with here, because once you get outside of the vertebral column in your skull, then you don't have these coverings, okay? So the nerves that travel down your arm and your leg and stuff like that, they don't have these coverings, okay? Now, if you ever look at an illustration, and you should be able to see real brains later this quarter, right? When you look at them, I want you to pay attention to something. Notice how it actually is showing you little vessels right there, right? So if you see like a brain or something like that, or you see like spinal cord tissue, and you can still see the vessels on it, more than likely, it's super rare, right, for this to not be the case, but if you can still see the blood vessels on the outside of the brain, then that means that the pia mater is still intact. Because when you remove the pia mater, you strip off all those blood vessels from the outside. So if you see a brain, and it's like nice and just clean, and it's nothing but neural tissue, and you don't see vessels, that means that the pia has been removed, okay? If you see vessels, pia's still on there, right? It's like this saran wrap that covers the brain, right, and the spinal cord. Now, the pia, right, there's going to be like a little gap, right? And so this gap right here, there's an actual space. There's a space right here. And then on the other side of that space, you have another meninx, another tissue, and this one is called the arachnoid. It's called the arachnoid because in real life, it has all sorts of like spiderwebby little trabeculae coming out from it. So it looks like a spider web, it looks cobwebby, right? So it's called the arachnoid mater, the spider mother, okay? Now, because that space, which we saw in blue, right, is underneath, it's deep to the arachnoid, it's called the subarachnoid space, right? So that's the subarachnoid space. So subarachnoid is between pia and arachnoid, okay? And then, adhering to the arachnoid, there's another layer, and this one is the one that's the outermost, the most superficial. And this layer right here is dense fibrous connective tissue, and it's really, really tough. So it's called the dura mater, the tough mother. That's actually what it's called, dura mater, tough mother. Okay? And so this one is the one that you're actually seeing right here. This is the dura mater that you're seeing out here. Right? So it lines the inside of your brain, lines the inside of your skull, lines the inside of your vertebral column, your vertebral canal, right? The neural canal. Okay? Now, as such, it actually is basically acting as the periosteum on the inside of your vertebral column and the inside of your skull. Okay? Now, what this is protective. Okay? So what it's doing is it's holding your neural tissues in place. Okay? So it's kind of anchoring your central nervous system inside of your skull and inside of your vertebral canal. Okay? Now, in order to make this a much more effective anchor and holding things in place, you're going to have, and what color did I use? This red color. You're going to have extensions of the pia right here. So this is where the pia comes directly off, and it actually crosses the subarachnoid space and directly attaches itself to the dura mater. Right there. Now, do you notice how I'm drawing these little pointed triangles, right? Because they're little pointed triangles, they look like shark teeth. And because they look like shark's teeth, they're called denticulate ligaments. Ligaments that look like teeth. That's what those are. And what those are doing is they are directly attaching the spinal cord to the dura mater by holding in between the nerve roots that are coming out. So when we look at the nerve roots, right, we're going to see that there's a dorsal root coming out right there. You can tell because there's the dorsal root again. Can you guys see the yellow? Yeah, you can see the yellow. There's a dorsal root coming out right here, and then there's the dorsal root ganglion, right? And the root actually is created, and we didn't talk about this in detail. I don't need you to remember rootlets. It's actually created by a whole bunch of little rootlets coming out. So all those little rootlets come together and give you the root. But what I want you to notice is the denticulate ligaments are in between, right? So it's root, root, and in between is a denticulate. And then there's a denticulate, and then a root, and then a denticulate, and then a root. So what that does is that gives you very strong attachment here, and then here, and then here, going all the way down your spinal cord. So it holds the spinal cord in place, okay? And that's a form of protection. Now, the nerves, right, are actually going to emerge from your spinal, from your vertebral column through those intervertebral foramina, right? And then that's how we named them, right? So we knew we had C1, C2, all the way to C8. We had T1 to T12. We had L1 to L5. And we named them like that because of where they emerge, okay? Now, don't forget that we actually have repeating segments, right? So it's C1, C2, C3, C4, and C1 is very similar to C2, similar to C3, similar to C4, and that's the result of the way that they formed. They formed from embryonic structures which were segmented, broken up into repeating blocks, okay? Now, not only are we going to see segmentation in the adult, but there's something else that happens, and it's very, very weird, is we're actually going to drag some of our neural tissue down in the caudal or inferior direction. Okay? So the segmentation part, right? If you dissect somebody, then you can actually see segmentation. You'll see nerves coming out, right? C1 to C8, T1 to T12. You can see that if you dissect. Even if you don't dissect, sometimes you can see evidence of segmentation, right? So when you actually have like nerve deficits and problems with like sensation, and they're trying to determine, do you have a sensory deficit? Which nerve or nerves might be damaged? They can do, like they either use like a pinprick test, or they have, I don't remember what that wheel is called, but it's like a spiky little wheel, and they run it across your skin, right? And they try and figure out where you can and cannot sense things. That depends on this, okay? So these are what are called, now, the name is exactly the same. These are called dermatomes. It's not the embryonic version of a dermatome. This is the adult version, and in the adult version, a dermatome is a strip of skin that is innervated, sensory innervation, by a specific spinal nerve, okay? And what that does is that allows you to not pinpoint, but be more accurate in determining at what level the deficit may be, okay? Now, the other thing, you can actually see evidence of segmentation, right, is when you get like an infection with like a herpes type of virus, right? And I don't mean like herpes, the actual like sexually transmitted herpes, but it's related, right? You can actually have flare-ups, right? And you get these painful, itchy bumps, right? Does anyone have any idea what I'm talking about?
Shingles.
What?
Shingles.
Yeah, shingles. You guys know what I'm talking about, right? Related to herpes virus, right? Do the shingles, do they, in some instances, right, do they follow like a particular band or pattern? Do you guys have any idea? Yeah, they actually do. What they're doing is they're traveling along the nerve. That's what they're doing, is they're traveling along the nerve, and so they will only inflame and irritate a particular dermatome. Look it up. If you want, look it up. And look up shingles and look up images. And you can see there's like a band sometimes. That's because of the natural segmentation that we as adults have because of the way we developed as embryos, right? Now, in addition to segmentation, right, we also have something very interesting, and this is the dragging down of our nerve roots and our nerves, okay? So the idea behind this is, when you were an infant, right, when you were young, when you were just a little toddler, right, you can see C1 is coming out right here. There's I should do a different color. So C1 is coming out right here, and then C8 is coming out right there, right? You can see L1 is coming out right here, L5 is coming out right there, right? Now, where the root is coming off of the spinal cord, right there, right there, right there, and right there, matches up pretty well with where the intervertebral foramen is located, okay? But what's going to end up happening is your body, meaning your bones, right, your muscles, your bones, all that kind of stuff, are going to grow faster, right? In fact, they're going to grow, and realistically, your central nervous system doesn't grow at all, okay? So at this point, what you should notice is your central nervous system, here's the end of your spinal cord, the end of your central nervous system right there, right? Did it change from the baby to the adult? The end of your actual central nervous system? No, it didn't change. But are you still the same height as you were as a baby? No, your bones grew and your intervertebral foramina moved a little bit further away from each other. So when that happens, what you're now going to see is C1, right, the C2, all those kinds of things, well, they're still coming out pretty close to where they originally came out, right? There's very little shift right there, okay? But when you look at the lumbar region and the sacral region, all of that, this is where L1 is coming off of the spinal cord. Where is that? Where in your body is L1 coming off of the spinal cord? Where are the roots of L1? In your thoracic region. It's actually up here. Although L1 is actually down there. And the reason why is because your bones grew and your intervertebral foramen moved down, but your CNS did not grow. So the roots of that nerve have to grow. So this is the dragging. It gets dragged down, and then it emerges at the proper level of L1. Same thing happens with L5. It's going to be coming off right here, and it's going to get dragged down like this. Right? So all these nerve roots, dorsal roots, ventral roots, all of them, the sensory roots, the motor roots, they all get dragged down. And when they get dragged down, they end up going like this. And so you can see they kind of drag down right here. And when they do that, they form what looks like a horse's tail. Okay? So because it looks like a horse's tail, we call it the cauda equina. Because that means horse's tail. So what you're going to see is the very, very end of your spinal cord forms this little triangle, a little cone that you see right here. So this little cone that you see right there is the very end of your spinal cord, your central nervous system. Because it forms a cone, it's referred to as the conus medullaris. That's what it's called, conus medullaris. That's the end of your actual central nervous system. Now, once you get past that, then inside, right, of your vertebral canal, because you still have a vertebral canal, a neural canal there, do you have any central nervous system structures inside of here? Do you have any central nervous, like do you actually have spinal cord or brain inside there? No. So do you have any upper motor neurons inside of there? No. So that cauda equina, which is actually made up of all these little fibers coming down like this. Oops, wrong color. All these little fibers coming down like this. Right? What's inside of all of these little fibers? These nerve roots that are then joining up and forming spinal nerve. What's inside them? Lower motor neurons and sensory neurons. Sensory neurons also. No upper motor neurons inside of there. That's significant because, right, if you have damage, right, so if you end up having damage, like something damages right there, right, so you get damage right there. Are you damaging any upper motor neurons? Nope, only damaging lower motor neurons. So it's very location specific, all right? Now, the thing that I just happened, I pointed right where that little arrow was, right? Phylum terminale, right? So do you remember we had denticulate ligaments and they go like this and they hold the spinal cord in place? Well, it wouldn't make sense to have the conus medullaris, the little tip, just free like this, able to just move around however it wanted. So we also have another extension of pia, and that extension of pia comes down like this and it anchors itself at the bottom of the dura mater. And that is called the phylum terminale. The